Morning, friends. And as we start today with this very interesting session, high quality, accessible healthcare and resource in low resource settings, it's my privilege to introduce the speaker, who I'm also privileged to call a friend. Dr. Vijay Anand Ismavel is a pediatric surgeon whose CV runs into 9 pages, so that will be a session in itself. But I will just say that he finished his MBBS from Kilpauk Medical College in 1987. Following that, his MS in General Surgery from Madurai Medical College in 1992. And then his MCH Pediatric Surgery from right here in CMC Vellore in 1999. But what stands out is not that, but the fact that he and his wife have spent 30 years in Assam in a mission hospital where they did pioneering work, and when they eventually left in 2022-23, it was a thriving secondary healthcare hospital. So I think he's very qualified to speak on this topic of high quality, accessible healthcare in low resource settings. Dr. Vijay, please go ahead.
For inviting me to talk on this topic. So most of what I'm going to say is about our experience at Mukunda in Assam. And these are the three major issues. There are severe geographical disparities within and between Indian states. The second is about working with poor people. How do we modify treatment for poor people? And working in places where the hospital or local environment is very low resource. So that is the multidimensional poverty index brought out by Niti Aayog in 2022. So it gives an estimate of multidimensional poverty from about 0.7 in Kerala to 51 in Bihar. So there's an enormous disparity. And it closely mirrors the number of doctors per capita in India. I think this is probably covered by earlier speakers. And the last 2 years, my wife and me have been going around visiting hospitals. We have visited these 115 hospitals. So it is very interesting to note that there are several places in India today which are as bad as Mukunda was 30 years ago. So it's not a problem which has been resolved. So my wife and me moved to that top dot in 1992 for our first visit and restarted the work there in 93. I have said journey of faith because it was unexplored territory. We did not know what we were going to face, and both personal and professional lives were completely different. So why did we go there? Because of missionary sort of call to service, but guided by this formula, the transformational impact of one person is equal to the population of a place divided by the number of other people like you in that place. So obviously, places where there are few doctors and hospitals have the highest potential for transformational impact. So that's the location. It's very close to the border with Mizoram and Tripura and Bangladesh. So this hospital was closed in the 1980s after about 30 years by expatriate missionaries. So there was an American doctor, Jean Burroughs, who worked for 25 years at Mukunda until they were all asked to leave the country. And then we went there and restarted it. So that was the hospital at that time. They were completely closed. Not only closed, all the equipment were sold. So the staff were paying themselves salaries by selling of the generator and then the tractor and so on until there was nothing much left to sell. So it was just empty, broken buildings. And there were 60 leprosy patients in the hospital. The maternal mortality and infant mortality were really high. And every place has its geographical problems. This is a problem at Mukunda. So once we have floods, this is the entrance to the hospital. So for the next 3 months, people can't enter. So not only people cannot come to the hospital, but hospital has no money, has no patients. So this happens about once in 2 or 3 years. So there are people who die in the car. So somebody starts off with obstructed labor and then they get stuck in one of these traffic jams and then they take the body back home because they couldn't reach the hospital. So there was a time when the hospital road 1 kilometer from the hospital was blocked and people are dying 1 kilometer from the hospital. They just couldn't travel the last kilometer. And there are no buses. And in those days, no trains. So people are brought down to the road like that. And then they hire a taxi, which might cost 4,000 or 5,000 rupees in those days, just to get to the hospital. So we made we gave a 30-year commitment to serve in this hospital as a condition for restarting it. So we did not have any obligation to be there, but we felt that was the right place to be. And we divided that into 3 phases of 10 years each. The first to become a stable hospital, the second to start 3 large projects which will have long-term impact, and the third to consolidate our knowledge, create awareness, and hand over to the next set of leaders. But in the first phase itself, we created this formulating poor-centric strategies, because in the first 3 years, we realized that most of the people were very poor. And unless the hospital was tuned to them, there's no real reason to have a hospital in that place. So these were the core values. And again, poor consciousness was one of the core values. So all practices, policies, and everything that we did was focused on the poor. So that is the statistics when I handed over as medical superintendent in 2019-20. So you can see it's a fairly busy hospital, especially in obstetrics. And now I think it's more than that. And that was how it was when we left. So I was the only pediatric surgeon in Manipur, Mizoram, Tripura, Meghalaya, and southern half of Assam. So these are the people. So they have food to eat because tribal people can eat anything. If there's no money, they'll get food from the jungle, but they don't have cash. So if you say, you need 5,000, then they don't know what you're talking about. Where do I get 5,000? There are refugee camps, internally displaced people. So recently we went to Mizoram. There are a lot of refugees from Manipur. And there are a lot of refugees from Myanmar. So these are refugees from Mizoram in Tripura, because there was a conflict between these Riangs and the Mizos. So these are all people who just get enough money to live on. They can't spend money on healthcare. So they all come late and they die of easily treatable conditions, which they shouldn't die of at a very young age. And in those days, we used to allow barter trade. So people can pay in chickens or eggs or fish, because the bazaar is only twice a week, and they'll have to wait for the next bazaar to convert their produce into cash. And this is, we did a lot of, we don't have a community health program in those days. We didn't have the money for it. So we went into every community to understand cash flow within the family, their practices, their cultural problems, social problems, economic problems. And we realized that when we tell them to pay 10,000 rupees, they're actually selling the house or the land or livestock, or they borrow at high interest because banks will not offer a loan without collateral. So how do we identify these people? So if you have community health project, you can go and check on them. But we see them only in the hospital. So we studied these poor people when they come to hospital, and we realized that there were some pathognomonic findings. So they keep asking about the bill. So if they have 5,000, they keep checking. So when it comes to 4,000, they'll say, please discharge, my grandmother is sick. Or they haven't thought about the food. So the first day they buy food for 4 people. Second day they buy food for 1 person and share the meal. And third day they buy biscuit to keep the children quiet. So these are things that you can't fake because it's a little painful. So if you can observe that, you know that this person is financially vulnerable and is on the point of going to sell the house. So you better do something about it. They want a sick patient discharged before he dies because the cost of transporting a dead body is very high. So while he's still breathing, you can get a cheaper taxi fare back home. So these are certain things which we can do. One investigation to clinch the diagnosis. So if you were restricted to only one, what would that one be? Because we can't afford many. One or few appropriate drugs. So we have to define what is the medical objective for this patient and try to give that one drug which makes a difference. So this is very important because somebody comes with hypertension and diabetes. So actually my wife and me managed medicine for the first 14 years till we had a physician, Shalom from here, and then Roshin. So if somebody comes with hypertension and diabetes and you give him 500 rupees worth of drugs, he will say, please give me for 10 days. Which means he has money for 10 days of the medicine you are prescribing. And 100% is going to default. He can't take it. But if he goes home, like suppose he's got diabetic neuropathy, a local quack will give him one injection of multivitamin, one steroid and one antibiotic. And he'll probably feel a little better. Whereas with the diabetic drugs, he probably won't feel better in the first week or so. So he'll probably choose the quack. So we need to have some way to get him to leave the quack and come to you. And we have to measure cost and risk versus benefit when we make our treatment protocols. So we give charity proactively before they ask for it, because poor people don't ask charity. So they will somehow pay the bill because they don't want to spoil the relationship with you. And some people say, give it as due. But we realize when you give due, they don't come back to hospital. They will come when they have the money to pay the due. So then we decided every year we write off all the due accumulated for that year. So it all starts off fresh. And gold standards. So everybody wants gold standard, which assumes that there is no bar on money. And there's no bar on investigations, which is far from reality in a remote place. So we developed what we call revised gold standards, which take into account the paying capacity of the patient and the in-house investigations, so that people don't need to be referred. So probably like for diabetes, why not give a drug which was effective 10 years ago? May not be as good as the one that we have now, but better than nothing. And we developed a lot of surgical revised gold standards as well. So for example, cancer drugs. So cyclophosphamide is so cheap, but in most of the new regimes, it's replaced by ifosfamide, which is more toxic, more expensive. So what's wrong with cyclophosphamide? It's made in India, easily available. So when I was doing my MS in Madurai, DM oncology patients, registrars were asked to develop customized protocol for one cancer for Madurai, taking into account the cost, the number of days from work, the need for GM-CSF and things like that. So it becomes possible to treat them at a low cost. So I feel MD postgraduates should not be taught protocols. They should be taught guidelines, which they should be able to adapt and customize to the patients and the hospitals where they work. Then we had what we call target pricing. So instead of costing, which is an excuse to increase the cost of treatment, we made pricing. What can a person easily afford? So for OPD, it was the cost of a village haircut. So the barber, whatever they pay, they can pay to the doctor. And there are certain things they are afraid of. One is ICU treatment. So they think if we go into the glass room, they'll have to sell the house. So we said that ICU will be 500 rupees per day, including ventilation and all procedures. And that is cross-subsidized by ultrasound, because we do about 20,000 ultrasounds at a good profit. So internally, we can decide how we cross-subsidize. And occasionally, somebody sells the house. And then that creates a very chilling impact in the community. They don't want to come to hospital. Hospital means selling the house. So we used to send our staff with the hospital's money to get back the house. It's not a very large amount, usually 60,000, 70,000. So it doesn't affect us. And occasionally complications. So cholecystectomy, patient develops a bile leak. Instead of going home, the next day is in the hospital for a month. So we write off the bill. Again, once in a year or twice in a year, small amount for the whole hospital, but a big impact on the community. So we don't have private rooms or private consultation because we don't want staff to be divided in their attention between the rich and the poor. And that creates large volumes of poor people and creates the brand image that this hospital is for people like us, that means for the poor. So all this was studied by a group from Wharton School of Business. And people are afraid to adopt poor-centric strategies because they're afraid of competition. So will they be financially viable? But actually it creates loss of competition because the nursing homes don't have private rooms, don't have general beds, and we don't have private rooms. So we are mutually exclusive. We get a type of patients who don't go to them, and they get people who don't come to us. And we were making a healthy income over expenditure in spite of all these poor-friendly statistics. So people were not coming for deliveries because they had a very convenient system of delivery at home, where the traditional birth attendants were also doing the work of the mother, cutting firewood and cooking and all that. So we were able to engage with those people and tell them, why don't you send them when they're bleeding or obstructed or eclamptic? And they started bringing these high-risk patients in the beginning and slowly started. So within a year, from 400, it became 1,400. Within 4 years, 4,500. So just giving money is not enough. We must understand social cultural reasons for health-seeking behavior. And MMR and IMR declined in the district. So no electricity and oxygen for many years. Oxygen had to come from really far away, so it had to be rationed. So that's my wife with my first tracheoesophageal fistula. So ventilated by hand for 4 days till the baby is okay, because we don't have oxygen or a ventilator. And that's that patient, the previous patient. They all did well because they had good ventilators and monitors. So this lady had a small mass, went to a doctor, was told that it can be removed, but the cost was equal to selling the house. So they said, let's wait. So after some time, it became bigger. So then they said it might be cancer. So they decided, let her die, because otherwise we lose her and the money. So they came to us because she was not dying. So we removed this mass, which is 35 kilograms. She went into post-decompression pulmonary edema, but then recovered and went home. But the biopsy was mucinous adenocarcinoma. So that's the problem, and the way decisions are made in poor people. So this boy has come for blindness. Actually, he's having acute leukemia. We had 3 patients like this. So this is a girl with massive hemoptysis. First surgery we did with the EMO machine and just debulked. But she came 4 years later with a recurrence. Actually, Kenny was there for the second case. We did a middle lobectomy and she's all right. So when do you decide to take a risk and not refer? Because for us to refer this patient would be to send to Calcutta for a patient who is actively bleeding. So ethically, it is not right. So we need to decide when we will take risks. So that is the machine we used for 10 years after my wife did her MD anesthesia, because it does not require oxygen and it does not require electricity. So we need to make them feel at home. So there the nurse is carrying the baby of a patient because the baby has been crying the whole night. So to give the patient some time to sleep. And the other one has no attender. So one of the staff are feeding them. So then they feel more likely to come again to hospital. So this patient had thalassemia, went for a stem cell transplant, but it's no use just referring them. You have to arrange all the logistics. Only then they'll go. Otherwise they'll go home and die. So this patient had renal failure and tetanus. This is a recent patient. So nobody has done peritoneal dialysis, but why not try it? So they tried and this patient survived. So I think all these are covered. So we started a school. So I feel if one more activity can be started by a hospital, it should be the school. It's completely transformed the community. We started with about 10,000 rupees by painting an old building. Now we have 1,200 children up to class 12. 5 are doing MBBS. Entire staff children are studying in the school. It also helps retention of staff. And School of Nursing is going to become a college. So the whole of Northeast India, we have people who are trained and sent back to those states. And insurgency is a big problem in Northeast. So we started a hospital in one of the most insurgent areas in Tripura, and that is being developed now into a bigger hospital. And global equity. So many countries have very poor healthcare, and we are part of the training of MD, global health and tropical medicine doctors who go and serve in these really remote places. So there are a lot of research articles. These are done at CMC when I was doing my MCH here. So gastroschisis was treated with a very complicated silo, was very expensive, available only in the USA. So this is Dr. Nainan's idea to make it out of a Euro bag. So a lot of people started doing it with Euro bags and IV bags. Similarly, for hydrated cysts, there was no real treatment. When the lung collapses and the patient develops a bronchopleural fistula, so this is along with Dr. Sudipta, we developed this technique which can be done in any small hospital and is very effective and very simple. This was my wife's thesis on how to manage perioperative hyperglycemia with just a burette set. And we discovered thiamine deficiency. We're seeing patients with neuropathy, cardiomyopathy, and infantile death, and we didn't know what was causing it till we had a patient with acidosis, which could not be explained, not diabetic, not in renal failure. We checked with Kishore in MICU, and he was saying probably thiamine, one of the rare causes. So the patient was given thiamine, acidosis reversed, and a lot of studies were published about thiamine deficiency. They have this neurosonographic finding in infants and other similar innovations. So this patient had complete strangulation of the entire small bowel. So if you remove it, he's got no bowel left. You cannot give him TPN, you cannot do small bowel transplant. So we just thought, why not put it in a bag and wait? So we waited for 18 hours and 100 centimeter recovered on both ends. So now he is all right. So that was published. This was a study along with a group in Oxford about the rich-poor divide. Why do people in poor countries die, and why do people in rich countries survive? And what are the simplest things we can do to make it better? That was done. 22 hospitals in India were part of that study. And I was doing all the echo at Mukunda. So we did a study on heart failure. So the problem is there's no cardiologist. We don't know what is causing the heart failure. Clinically, patient has heart failure, but without echo, we don't know structural, functional, or is it not a cardiac problem? So we trained obstetricians to do echo. So that was published in Journal of American Society of Echocardiography. So they were trained to get 6 views. So they're all good at holding probes. And that it showed that obstetrician trained for 3 days can get sufficiently good quality images to say, is this a cardiac or not? And if it is cardiac, should it be treated here or referred? And that is enough. So I was also involved in a project with Niti Aayog. And then we suffered a lot of problems in the early days. There's no money, no people. But about 20 years, we couldn't take our annual leave. We lived without electricity for about 14 years. So all this could have been easily helped by a little bit of money, you know? But the problem was we were invisible to donors. How do you make hospitals which are doing good work visible? This is another study along with Wharton, which is going to be published. So these are a lot of things that are going on. So I have developed a device which can take blood out of the peritoneal cavity in ruptured ectopics, filter and put it back. So that has been published as demonstrated to Harvard and is all patented. We are going to do phase 1 trial at CMC. And another device to predict the onset of preeclampsia by doing a simple urine test, point of care test. So that is also developed by collaboration IIT Madras, and the phase 1 trial is going on in Makunda. So unless we involve the government, we can't make large impact. So in 2008, we got into a public-private partnership and got invited by District Health Society. So involved in a lot of government initiatives. So there are obviously difficulties. I would say temporary trivial inconveniences in exchange for impact. So I had a MI, there was no streptokinase. So I was treated at Makunda, and my ejection fraction is 35%. So 100% block of left anterior descending, acute thrombosis. Then I developed leprosy, and then all sorts of reactions and hypokalemia, hypoglycemia, tremor. But then I am all right. And there's no money for the first probably 15 years. A lot of local problems. They wanted us to leave because they are interested in the land. So we had about 6 criminal cases against us, false cases to get us to leave, and civil cases and labor cases and all sorts of things. So this is the CMC Vellore Mission Hospital Network, 185 hospitals, and you can see that plenty of them are in those poor areas. There's one of our junior doctors in a really remote place. So people have to travel 6 hours by that hammock to reach the hospital. And he amuses himself with a pet squirrel. I also got interested in biodiversity documentation and research at Makunda. So these are some suggestions that we reorient our medical education by developing revised gold standards. So if you train somebody at CMC in Western protocols and put him in a really remote place, he is going to feel totally lost. So so this is what we teach our MD global health people. Scenario analysis. What will you do if this is not there, that is not there, no money? So they have to come up with a way to manage the patient. And probably that should be part of medical education. Teach life-saving skills like point of care ultrasound, basic anesthesia, and hospital management to all the people who live from here. Support and handhold sick hospitals. Advocate for greater support for places with high potential for impact. Recruit, train, position, and handhold. Because the greatest impact is by sending people physically into places of greatest need. Unfortunately, a lot of temptations. India is becoming highly corporatized. People get a lot of money by getting incentives. So people have to choose. So will people take the less trodden path? I think that will be the single most important thing to make a difference in remote places. Thank you.
Thank you, Dr. Vijay. That's the kind of talk which, either has a lot of questions or you're completely hushed into silence. But we will have some time for questions. But just to get things started, you mentioned many things that you could do over 30 years. I'm just thinking, what were the things that were left undone?
Yeah, so we actually wanted Makunda model phase 2, which we didn't do. And that was, we realized that the biggest expenditures were not in hospital. They were out of hospital. It was transportation, loss of wages. So we were thinking how nice it will be if in each of the towns we had Makunda certified practices. So we diagnose diabetes, but they manage. They come only for complications. And Makunda certified taxi service. So they get less expense on the transportation. So that would have been a second phase of decreasing costs for poor people.
So there's a very practical question from someone here. He says, how do you generate cash and for salaries when the population is poor and you have to write off so many bills?
Yeah, so I just put the figures there. So in 2019-20, we had a turnover of 23 crores. Out of that, 3.5 crore was given as charity, and we had an income over expenditure of 1.5 crore. After subsidizing the school for 40 lakhs, nursing school for 10 lakhs, and the farm for another 5 or 6 lakhs. So it was making a profit, and that is because the volumes were so large. So if you have 7,000 deliveries and a large proportion of paying, we are charging 5,000 rupees for a delivery, 10,000 rupees for a cesarean section, and making a profit on it. So volume is the answer to sustainable, low-cost, high-quality care.
We're running a bit short, so I'll just one last question, Dr. Vijay. What is your experience in dealing with the government agencies who may be overseeing or even monitoring your work? And what would it take for the government to take over your model and replicate the work that you're doing?
Corporates.
No, the government. How do you experience dealing with the government agencies who may be watching or monitoring your work, and why? And has the government taken over any of your models to implement on a larger scale?
The government invited us to be part of the not-for-profit hospital study done by PricewaterhouseCoopers. And a lot of our ideas got into the document. And in Assam, a lot of our ideas have gone into the district and also to the state. And they are very happy with us. We are the best functioning private-public partnership in Assam. And whenever any guests come, they bring them to see us. And they have also given us a lot of financial assistance. The biggest financial assistance to Mukunda is from the Assam government and the Indian government. And when the BJP also, when they came to power, they came to see the hospital because there are a lot of complaints. People had raised complaints about the hospital. But they were so impressed that the MLA, on his first visit, said, I'll give you 1 crore. So government works closely with us.
Thank you, Dr. Vijay. He's a very approachable person, so you can catch him anytime during the day, and he will be more than happy to talk about his work and any questions that you may have. Thank you very much.
I now invite Dr. Kenny to give a memento of our appreciation to Dr. Vijay Anand.